Hello there. Good afternoon, everyone. My name is Nick Lipley, and I'm the CPD editor at RCNI, the publishing arm of the Royal College of Nursing. And welcome to this seminar. Hold on just a minute, if you don't mind. And welcome to this seminar entitled Appropriate Management of Lower Limb Wounds. It'll last 90 minutes, during which time we'll be hearing first from Sarah Gardner, Director of Wound Care Consultancy Wound Care Matters, on the latest best practice, including recommendations, the latest recommendations from the National Wound Care Strategy Programme. They were published towards the end of last year. We're then going to have a brief Q&A session, about 10 minutes. Our Q&A session lasting about 10 minutes with Sarah. And then for the panel discussion, Sarah and I will be joined by three practicing nurses, Emily Bishop, Martha Williams and Emma Williamson, to discuss the practicalities of making these things happen, making these recommendations happen, their successes, personal successes, and the challenges that need to be overcome. We'll then have a second Q&A session, and so as we hear, so that's two Q&A sessions. So as we hear from Sarah and our panelists, please post your questions. There are details on your screens, so we can get through as many questions as we can. This webinar has been brought to you by HARTMANN, the producer of wound management products and platinum sponsor of the Legs Matter Coalition. So let me introduce Sarah very briefly. As I said, she's an independent tissue viability consultant, but she is also vice chair of the Legs Matter campaign. And a member of the National Wound Care Strategy Programme Lower Limb Group. So, Sarah, over to you.
Thanks very much, Nick, and thank you to HARTMANN for inviting me to speak today. Welcome to everybody. Could I have the next slide, please? And the next slide. So yes, this is me. Just to say that I was actually a tissue viability lead in Oxfordshire up until mid 2020, and leg ulcer management has always been a great passion of mine. So I'm delighted to be able to share the recommendations from the national strategy today, and I think it'll make a brilliant debate with our panel later on. Next slide, please. So, first of all, why does leg ulcer care need improving? Well, I remember many years ago when I started nursing 40 years ago, I worked on a dermatology unit, and I still in my mind can visualize a very elderly lady with bilateral leg ulceration. She was in her 90s, she was a farmer's wife, a very stoical elderly lady. And I can still picture this lady in the bed with these leg ulcers and the pain that she was experiencing, the smell from these leg ulcers, but sort of how brave she was with it and how stoical. And I remember thinking, what an awful condition to have. And that surely, you know, this is something that can be healed very quickly. But even back then, and I then reflect sort of over those 4 decades, have we really made much difference? I'd like to think we have, but still it isn't ideal. There's still patient suffering, and it's an acceptable situation, and that is sometimes with the patients themselves, but also from us as clinicians, from general practitioners, from our GPs. It seems to be that it's disease of old age, that swollen legs, that ulcerate happens with old age. I remember discussing leg ulcers with a GP that I worked with when I was trying to get representation on a sort of study day that we were running, and I wanted to try and get GPs to this study day to try and look at solutions for improving leg ulcer care. And I was really struggling getting engagement. And I remember him saying to me, well, the thing is, Sarah, is leg ulcers aren't sexy, are they? You know, they're a disease of old age, and it's not very exciting. You know, give us juvenile diabetes, that's exciting. And I remember thinking, this is just awful. And I really genuinely don't think that an awful lot has changed, excuse me, over the decades. Next slide, please. But luckily, there are lots of people that are passionate about this and want to make a difference. And we now have a national wound care strategy programme that has been commissioned by NHS England, and that incorporates a number of work streams, with lower limb being one of them. These work streams are supported by very important sub-work streams around research and evidence, because it's so important, isn't it, that anything that we do clinically is supported by that evidence. It needs to be credible. Supply and distribution, because obviously procurement is a really important part of this. Data and information. Again, we need to capture data to demonstrate that we're making a difference, or demonstrate why we need to change our practice. And fundamentally, education is essential if we're going to have skilled, knowledgeable practitioners delivering the care. So next slide, please. So the national strategy that placed an importance on the lower limb work stream because of evidence that came out of a study back in 2015 from Julian Guest et al., who was looking at the burden of wound care on the NHS in the UK. And what was very striking from that evidence was the data that came out around lower limb wounds, leg ulcers in particular. So we know that there are about 2% of the UK population affected by active leg and foot ulcerations. That's about 1 million people. And in fact, a recent study that he's done an update on that, this number is increasing. A significant number of these people have a venous leg ulcer. And actually, although that's quite depressing in terms of a figure, that really is probably good news, because actually venous leg ulcers are relatively easy to treat. So why have we still got these people with open ulceration? The costs are significant. Back in 2015, the costs were over £3 billion associated with lower limb wounds, and that actually has increased over the last 3 years. It is very costly to manage somebody with a non-healing wound. A lot of that cost is associated with clinical time, but we know that it is the variation in practice and the outcomes being produced which increases that cost, the cost of that care. But fundamentally, we know that actually it's unacceptable that people are living with this condition when something can be done about it. Next slide, please. So, as I said to you, the biggest proportion of leg ulceration is associated with venous insufficiency. So there's a problem with the veins, and you get this sort of backflow, this reflux, which then has a knock-on effect, and people develop ulceration. But we know that there is huge amounts of evidence that supports strong compression being applied to that limb, as well as that combination therapy with endovenous surgery as first-line therapies makes such a huge difference. And we can be achieving healing rates of 85% at 24 weeks. So that is being proven in our evidence. But the data that we have through the studies being run is that actually we've only got healing rates of about 47% at 12 months. So this unwarranted variation does provide a really strong argument that we need to change the way that we run leg ulcer services, or how we deliver that care. And we need to stop using ineffective treatment, which we know that is happening, and apply evidence-based to try and get these figures that have been demonstrated through the studies. Next slide, please. So, when the National Wound Care Strategy programme started, we formed a lower limb work group, and that was it was a real mixture of people. It was vascular surgeons, tissue viability experts, podiatry, because this was around lower limb wounds. I'm talking to you today just about leg ulceration, but the group actually encompassed foot ulceration as well. And they brought this body of real experts together to develop these recommendations, which were went out for consultation very widely and were implemented or made available back in November. So what they are hoping to achieve is they will be a signpost to relevant clinical guidelines. There are already guidelines out there which are evidence-based, but they've incorporated a lot of these into their recommendations, and it will provide this outline of evidence-informed care. And what they are trying to achieve is that if they're implemented, it will hopefully create rapid diagnosis. So rather than, you know, a patient being on a nurse's books for 6 months without a proper diagnosis, which the GUESS study identified that many people didn't have a definitive diagnosis for their lower limb wound. What we're trying to achieve is that a diagnosis will happen very quickly, because if you don't get the right diagnosis or the right etiology of the ulceration that you're managing, how on earth can you go down the right treatment pathway? So it could be risky or it could be totally ineffective. And what we're trying to achieve is that there'll be fast access to appropriate therapeutic interventions, and that if that patient is quite complex in terms of their underlying comorbidities, for example, or maybe their vascular supply, is that there'll be swift escalation for treatment or service provision for these complex patients. And they can be applied, these recommendations, to all clinical care settings, and it won't replace necessarily the existing evidence guidelines that people might have access to. But I would suggest that if you have policies in your areas associated with lower limb care, they do need reviewing, because I think, you know, they do become outdated and we should always be updating them with the most recent evidence. They shouldn't replace clinical judgment and decision making in relation to the individual needs of the patients. And that's really important, because we aren't dealing with robots here, are we? We're dealing with human beings, each with individual needs. So the actual fundamentals, the core bits of the recommendations should be applied. But of course, everyone has different needs. It could be around just limb shape, it could be the circumstances around in that patient, in how maybe they would tolerate certain treatments. And I think, you know, we often know our patients really well, and it's about working with our patients to ensure that any recommendations that we make are acceptable to them. Many of us have a wealth of experience out there, but it should be evidence-based. We have this tacit knowledge, don't we, these of us that have been doing this job for a long time, but we need to make sure, is that most up to date? But please, you know, do treat people as individuals and not just, you know, as a sort of one stop for everybody, really. Next slide, please. OK, next slide, please. So let's go through now the main recommendations from the National Wound Care Strategy Programme. Next slide, please. So the first thing that's being suggested is around immediate and necessary care. So Betty, I don't know why Betty came into my mind, but Betty bashed her leg on a car door 2 weeks ago, a small wound. She's been managing it herself, but things have got worse. So now she's presented at the GP surgery to see the practice nurse with this wound. What they're saying is that when Betty presents to you, it's around doing an immediate assessment against some red flags, which are listed here in red, and then moving on with immediate care, which includes reduced compression of up to 20 millimetres of mercury. Now, this is without a Doppler, and there'll be some of you out there that'll be going, oh my goodness, no, we can never put any compression on without having done an ABPI first. But what this recommendation is that if Betty has not got any of these red flags, it will be safe to apply reduced compression. So simple low adherent dressing with adequate absorbency and a reduced compression garment, and that could be a class 1 hosiery garment or it could be a reduced compression bandage. Basic skin care, wound care, and then the compression. But if Betty hasn't healed in those 2 weeks, there's probably something going on that is making this more complex. So at this point, you need to try and establish, is healing going to be difficult for Betty? And if so, you'll need to refer that patient on to somebody with more advanced skills in leg ulcer assessment, and that should be done within 14 days of Betty presenting to you. Next slide, please. So this might create some challenges to you. So I suppose we need to ask ourselves, who will be seeing Betty at that first point of contact? Now, it's not necessarily going to always be a registered nurse. It could be a non-registered nurse like a healthcare assistant, or it could be a registered nurse who hasn't got a lot of skills or knowledge with wound care. So I suppose the question is, and we can talk about this in the discussion, is will those red flags be recognised? And will that person recognise this wound as potentially a complex or a hard to heal wound? What constitutes reduced compression? I suppose, you know, individual surgeries or district nursing teams might not have access to these modalities. So will you be able to apply that reduced compression at that point of contact? What about local policy? If local policy is saying, no way, you can't put any sort of compression on without an ABPI, that's already going to maybe create some problems, isn't it? So again, questions to be asked. And how can we challenge or change this historic practice? This is a massive change in practice. So how do we address that and move that on? And I'll be welcoming that discussion from our panel later on. But also what they're trying to suggest is that, can that patient self-care at that point? Because part of this strategy is we should be moving to more self-care or shared care models, if at all possible. Next slide, please. Okay, so Betty has been deemed as being complex in terms of healing. So she is now being referred on to an advanced skills practitioner for a proper diagnosis and treatment plan for her leg wound. Okay, so when we talk about advanced skills practitioner, we don't need it to be a tissue viability nurse at this point, or a leg ulcer clinic, or a vascular specialist. This can be a generalist nurse, but who has received training for managing leg ulceration. So she's got some advanced skills, or he's got some advanced skills. And at that point, there should be a holistic general assessment, including medication review, pain assessment, is there infection present, establishing the nutritional status. There should be a wound assessment using the minimum data set. There should be some wound imaging in terms of photography. And then there should be a lower limb assessment, including an ABPI, neuropathy assessment in terms of is there a change in sensation which might, you know, interfere with your decision making on compression, possibly. And then you'd be doing that lower limb assessment, so looking for skin changes, is there lymphedema present, etc. When you've done all that, that should establish what etiology or a diagnosis. So what is going on with this? Have you eliminated vascular arterial disease? So what I'm dealing with here is a problem with the veins. And then you would formulate a plan. And again, if nothing is complicated in terms of wound care, keep it simple, follow any guidelines for infection, give advice on footwear, exercise, mobility, leg elevation, etc., etc. Next slide, please. So again, challenges possibly. Who are these practitioners with advanced skills? Are they in your workforce? And how do you ensure that they are seen or assessed within the 14 days? Will all of those recommended assessment criteria that I've just mentioned be completed at the first visit? Or have you got to spread it out over a number of visits? How will the assessment outcomes be communicated with the wider team? Because it's likely that that clinician won't be responsible for the day-to-day care. And who will be making the decisions on the wound care? And how can you ensure continuity? And how can self-care or shared care be made the default for treatment? Again, it goes back to this is a real change in how we practice. Next slide, please. Compression forms a huge part, it's a big cornerstone of this recommendation. And what we are doing at this point is this: if the patient has adequate arterial supply, they should be immediately referred for surgical endovenous intervention and then put into strong compression. So this is not the reduced, you shouldn't continue with that. This is a minimum of 40 millimeters of mercury at the ankle. This slide just demonstrates that if a patient has got the presence of oedema, or they've got a large limb, or they've got high levels of exudate or very fragile skin, the recommendation is they go into multi-component compression bandaging. If they have got a nice standard size limb, a good shape, low levels of exudate, a smaller wound, you should be considering a 2-layer hosiery kit. And that's a really good opportunity to then implement that self-care, shared care model. Next slide, please. Challenges maybe. So will all patients be referred to the vascular service? Who does that? Can the local service cope with the demand? There's commissioning issues here. What are the commissioning arrangements? Will GPs be prepared to routinely refer these patients? How can we ensure that full or strong compression is applied and that people don't just continue with the reduced compression? What about the skill set of the clinicians putting that bandage on? Are you confident that they've got those skills? And what about dressings? So if you've got a very wet wound and you need some absorbency, is this a problem? Which product should we be selecting? Does that interfere with the sub-bandage compression that you're trying to achieve? Leg ulcer hosiery kits, how do we convert to these? This is a prescription often. How do you measure which is the best to use? And how can we facilitate self-care? Next slide, please. If the patients have got signs of arterial disease, your patient should be immediately referred for a vascular assessment. Now, often these patients will have combination disease, so they'll have an underlying venous component. So again, it's important that we try and treat that if the patient stands a chance of healing. But it's around working with the vascular service to establish the safety to apply compression if there's some mixed disease there. And, we should be following NICE guidelines for peripheral arterial disease because of this. Next slide, please. So again, challenges: recognising when it's safe to compress, treating the venous component. Whose decision is that? Who makes that decision? Is it vascular? Is it your tissue viability service? Is it you? And timely referral. If patient's going to have to wait for 3 months to see the vascular surgeon, could you not treat the venous component safely? How do we communicate what we're doing across the services? Next slide, please. The next bit of the recommendation is around monitoring progress. And the recommendations is that, every time you're seeing your patient, you should be, taking note of, is the treatment plan looking like it's effective? How's the patient been in that last week, in terms of comfort? Have they had any pain? How are they coping with the treatment plans, such as the compression? Are they managing, to elevate their legs? Are they mobilising, etc.? Formally, every 4 weeks, you should be doing your minimum data set assessment for the wound, establishing, has there been a reduction? You know, we should be aiming for a 40% reduction of that wound size within 4 weeks. So take photographs again. That can be quite powerful in terms of sharing that with patients as well, when they can become quite despondent that maybe they're not progressing. Imagery is really good way of saying, you know, look at this, you know, 4 weeks ago it was this, now it's this, look at the progress being made. It's really important to monitor progress because weeks go by, don't they? And also, you know, it's not always the same person maybe doing that assessment. So how do you establish that things aren't improving? Because it's really important that if progress hasn't been made at 12 weeks, you should be referring to a leg ulcer specialist or tissue viability for an assessment. Don't forget, those of you in the community, this is really important because it's part of a sequence which is coming your way in terms of demonstrating that all of these criteria are in place and that, that you're making a difference in terms of healing rates for patients with leg ulcers. Next slide, please. Challenges then. I think I've always mentioned, who's going to be monitoring this? What about continuity? Recognising that failure to progress. Technology. Referral pathways, you know, who do you refer to? What's the demand? Have you got to wait for that? And data collection. One of the things that's been identified as part of the national strategy work is the difficulties in data collection on, you know, people have different systems, they haven't got systems at all. So it's about how do you extract that data that demonstrates whether you're making a difference or not. And this is why the national strategy have got a particular work stream looking at data and systems to use, technology basically. Next slide, please. And then the post-healing, the exciting bit that the patient is healed, but we need to prevent that recurrence. So hosiery is a really effective way of reducing the risk that patients are going to get that ulcer back. But if patients have been referred for their endovenous surgery, that has demonstrated that the risk of recurrence is much lower if they've received endovenous surgery. But also, in addition, the wearing of hosiery will improve that statistic in terms of the risk of recurrence. So compression hosiery, people in compression hosiery should be reviewed every 6 months, and patients should be given information about what to look for and what to do if they have any problems, general education around weight loss and nutrition and exercise, and that should be supplemented by written information about what they need to do, who to contact if they have a problem. Next slide, please. So is there a challenge to that implementation? You know, who leads on this? Who is responsible for this? Have you got that information available to give to patients? We know there are challenges of donning and doffing hosiery, but it's not impossible. There's improvements all the time from companies who produce these garments and the aids that go with it. And I think we need to, you know, really work on that because you know, if we're not confident in applying hosiery with some of these aids, how can we then translate that to our patients and expect them to be doing it? How do we recall for remeasurement and new prescriptions? Is that the patient's responsibility? Is that our responsibility? So again, we need to think about that. And also, I think we need to start talking to patients about that you are in remission with your ulceration rather than we have healed you, because it is a disease and it can reoccur. So I think we need to think about the language that we use and to maybe start talking about remission, I think. Next slide. So in summary, the recommendations are now available, but I think from my presentation, you will admit there are challenges to implementation, but I think it starts now. You know, we have to be looking at what those challenges are and start looking at solutions. The recommendations are evidence-based and demonstrate better healing outcomes if we can get those into practice. We need to, as I said, identify these challenges and look at solutions, but I think it provides some really exciting opportunities for service redesign. We need a collaborative approach, and the priorities, and I think historically leg ulceration has been way down on the priority list across commissioning, across clinical services, and we need to revise that and bring that up that list, I think. We can't accept the current status and that you know, this is as good as it's going to get, because collectively there's a lot of you out there today listening to this, and collectively we can make things happen, because absolutely legs matter. Next slide, please. Thank you. Open for questions now.
Hello.
Thanks, Nick.
No, thank you very much. Can people hear me okay? Yeah, hi. Hello again, everyone. Sarah, fantastic. Thank you very much indeed for you know, a fantastic presentation there, bringing us up to speed with the latest recommendations from the strategy program. Really informative and very, very relevant to practice, as I'm sure we can all appreciate. And we've been getting lots of questions coming in. So let's just turn to the first one that's come in. I know, Sarah, you mentioned during the presentation which products. Someone's asked, I would like to know the best way to manage chronic leg wounds in older people, best products, etc. So with that in mind, over to you.
Yes, I mean, I think when we talk about products, again, it goes back to, before we can decide on anything that we're going to put on, I mean, when they say products, possibly they're referring to dressings. So even though dressings are really, really important, I think fundamentally, if you have a lower limb wound, it's going to be the compression and any venous intervention, whether they have to have you know, surgery, as I said, that's going to make the real difference. But until that point of healing, of course, we're having to put dressings on the wound. I think it all goes down to your wound assessment. So the recommendations, whether that be through the Scottish guidelines, which are the sign guidelines that we're using, and the recommendations from the national strategy, is keep it simple. So if you've got a fairly clean wound, it's a contact layer with adequate absorbency. So, you know, that's going to be really what you have access to in terms of your formulary. But I would say with elderly people, it's the importance of managing their skin and preventing any further damage, and then really thinking about the compression system that's going to be best for that elderly person. So it could be, if they've got very fragile skin, trying to get a compression stocking on might increase the risk of trauma. So a bandage is possibly the better solution for them. You don't want to put anything adhesive in terms of adhesive dressings onto the skin, because that can increase skin tears. But something that's not going to stick to the wound, is not going to cause damage to the skin, but giving adequate absorbency is what I would recommend.
Okay, that's thank you, Sarah. In a related question that's just come in, I work with patients who often have to wear IPC, intermittent compression garments, worn from ankle to thigh. Any implications for leg wound treatment on that one?
So intermittent compression is usually applied. Well, it's where you get sort of airflow, so people can wear garments, you zip them on, and that's sort of, you plug it in, and what it does is it produces a squeeze onto the leg over a period of time. So what it's doing is it's squeezing the calf pump muscle, so encouraging blood flow in the veins back up to the heart. And also it does help sort of stimulate the microcirculation as well. So it's, in my experience, it's not a commonly used garment. It is used in some specialist areas. If you are using that, it is a form of compression, so it can only bring benefits to a lower limb wound because it is enhancing the blood flow in the veins and, as I said, the superficial circulation. But I would sort of question why intermittent. Obviously, it's been used for a reason. I mean, usually people with leg ulceration, they have got a permanent compression garment on, whether that be a bandage or some sort of hosiery garment. But if they're using intermittent compression, as I said, it will only enhance healing, so it's a good thing.
Right, thank you very much. And again, another question about products and hosiery here. What about prevention when we notice erythematous shins and swollen lower legs? Asks one of our guests. Should we not be proactive in getting those at risk into the right hosiery to prevent ulceration?
Oh, you're a person after my own heart. Absolutely. I mean, the thing is the National Wound Care Strategy lower limb recommendations are based on lower limb wounds. So even though if you read, and I would really recommend that you can access these recommendations online, and they do refer to prevention, because prevention, I mean, legs matter. If none of you have ever been into our website, I urge you to do it, because there is such a huge amount of information there, and we're very much promoting that prevention agenda. So if you've got red legs and you've got oedema, it's because very much of that congestion in the veins, and ignoring that and not putting that person into some compression is only, you're on a road to disaster, really, because what will happen is that that patient will be at risk of developing infection, so cellulitis in that limb, and every time you have an episode of cellulitis, the condition worsens, and ultimately in time that limb will possibly ulcerate. So I'm absolutely 100% behind you that if someone presents in your clinic, or you're a district nurse and you see them, for example, and they're presenting with swollen legs or red legs, it's likely to be to do with the veins. Get them assessed and get them into compression. So that could be, hosiery is ideal for that. Sometimes if the limb is really, really big and filled with fluid, we would try and decongest that limb with bandaging first, and then get them measured and into hosiery. And by doing that, you really reduce the risk of disease progression and problems further down the line.
We've got a question here which still on products and dressing. However, which takes more of a holistic look at things, which I'm sure you'll be interested in asking. The question is, I used to have a patient with lower leg wounds. She has dementia, and it's almost impossible for her dressings to last because she kept removing them. She might have found the dressings itchy, warm, etc. We tried to help as much as we could, but it was difficult as she couldn't communicate appropriately too. Any suggestions? And there's a thank you attached to that already, but over to you, Sarah.
It's a real problem, isn't it? When I was in practice as a tissue viability nurse, we would have referrals describing your scenario here. Sometimes we found that when people with dementia were removing bandages, hosiery, dressings, and as you say, they couldn't communicate, pain was often an underlying feature, but they couldn't articulate or that they had pain. So I would make sure that they're having adequate pain relief. There's a tool called the ABBY tool. I don't know if you've heard of it, but it's around how you can assess people who can't articulate, whether they have dementia, for example, through the non-verbals and other ways that they demonstrate pain. So it might be worth just trying to assess for pain, or routinely giving them some mild analgesia such as paracetamol regularly to see whether that sort of just reduces the discomfort that they might have, which is making them take their dressings off. Itch is a problem, so again, good skincare, so making sure that the limbs are really well hydrated with, moisturized well with a non-perfumed product, because the skin barrier in elderly people does deteriorate with age, and can cause, itch and discomfort. So making sure the skin is good, making sure that the dressing, is maybe a silicone backed dressing. If you haven't got a bandage on but you need to hold a dressing on, avoid anything really adhesive and use a silicone based product which is kinder on the skin as well. Thigh length garments can sometimes help because it's the below knee that they can get to, so that's maybe a solution as well. So it's a bit of trial and error, I think, but a difficult one to manage sometimes.
Well, great, thank you, Sarah. We have quite a few questions coming in about training and staff support in that area. So I'm going to try and we've got lots of questions, so I'm going to try and combine some of these, if that's all right. First question, very broad. Can you recommend any good courses to develop our knowledge and skills? But hold that thought before you go on to that. There's a question here, sorry, just to scroll down. Oh yes, scroll up, should I say. It can be difficult in nursing home environments to access help and training. Have you any suggestions how to address this? Community nurses do not come into nursing homes, yet they often have the knowledge. What future training will be accessible to care homes? I'm sure the community staff would be rushing there if they could, but over to you, Sarah, on that, really about training.
Yes, I mean, I think it's all dependent on different areas, to tell you the truth, Nick. I know when I was working in Oxford, we did offer our training to nursing homes. They were able to access our training. I agree that community nurses don't go into nursing homes, but they go into residential homes. But, in terms of them being so busy, they often couldn't provide sort of formal courses. But, area to area will provide access to that. I know that I'm a trustee for the Tissue Viability Society, and we do put on virtual basic and advanced study days, which can be accessed for free by anybody. So it's worth looking on our website. And also industry are amazing now in providing training, and most of it is non-branded. And it's very generic and really good. Often they have clinicians working in their companies. So I would speak maybe to some companies. HARTMANN is sponsoring this event, and I know they have brilliant online courses. Look on the Legs Matter website as well. But I must just add that the National Wound Care Strategy are developing a program of e-learning educational sessions, and that will be coming out. So again, that will be accessible to anybody really delivering leg ulcer care.
Sorry, just turning myself on and off there. Great, Sarah, thank you very much for that really insightful view of lower limb wounds. What I'd like to do now is to bring in the other panelists. So we have here, just one moment. Yes, I'd like to bring in our team of panelists, as I say, who'll be setting out for us some of the challenges that they face on a day-to-day basis, and also some of the more general thoughts about the issues. So let me. I won't give you too much preamble about this, but let me just remind everyone of who we have joining Sarah and myself. We have Martha, excuse me, Martha Williams, Emma Williamson, and Emily Bishop, and they'll be introducing themselves in that order. So first up is Martha Williams. Over to you.
Hello, my name is Martha Williams. I qualified as a nurse in 2016 from the University of Worcester, and since then I've been working as a community nurse for Oxford Health, and more recently I moved over to their community tissue viability team, so I've got some experience in both of those areas. Thank you.
Lovely. Thank you very much indeed. Next up is Emma. Over to you.
Yes, hello. I'm Emma Williamson, and I've predominantly worked within the primary care setting, but also had some experience within A&E, and my first initial experience with below the knee leg wounds was when I worked within a community team or within Suffolk. But basically one of the surgeries that I previously worked at within Bury St Edmunds, we were presented with the leg ulcer contract. So basically after taking on the lead role, we tried to work as a team together and researched into like what was the best way that we could actually deal with patients who did have leg ulcers or below the knee wounds, because the feature that kept coming up with the nurses was that we always didn't have enough time. And actually the thing that was taking up the most amount of our time was the need for these leg ulcers. So basically created a pathway which included the holistic elements of looking at the whole person and working within the community and the team. And basically we had a great audit with great success rates, and yeah, and the pathway went on to win awards. And I've looked at working with the other surgeries and other practices within Suffolk to implement this pathway, which has now sort of become standard for where I work. So yeah, thank you. Thanks for inviting me.
Thank you very much for being here. That's everyone. I haven't missed anyone off, have I? No, don't think so. Right, so that's splendid. One of the questions which came in earlier, and this will really be one, I think, for Emily. I think one for Emily. Just bear with me. Sorry, forgive me. Is in an ideal world, would it be useful to have leg health promotion like we currently have heart health promotion?
Hi, so yeah, I'm Emily Bishop. I'm matron for community nursing down in Oxfordshire as well. Just to give you a bit of my background, I've been qualified for over 20 years, 10 years of which have been in the community. So predominantly I look after district nursing as well as the tissue viability service. So a lot of my interest is kind of seeing the overarching on how we can interlock our care for our patients, which is obviously predominantly a lot of tissue viability issues that are risen up, especially in district nursing, and how we can best deliver that service. So Nick, could you just go back to the question?
Yes, of course, Emily. I missed you out, didn't I? What? What a slap wrist there. I'm so sorry. It's all the excitement, as you know. The question here is, in an ideal world, would it be useful to have leg health promotion like we currently have heart health promotion?
I completely agree, 100%. Yes, I think, you know, prevention is always going to be better than actioning and treating anything in any condition, not just leg matters. But I think also with leg ulceration, this is a long-term problem for most of our patients. This is not a quick solve, something that we go in, treat, and we never see these patients again. A lot of our community patients have a huge amount of comorbidities. They're not just a straightforward person coming onto our service. So actually, if we can do prevention, and actually if we can get an awareness of the people who are 30, 40, 50-year-olds to start looking after their legs. So actually when they are the 50, 60, 70, 80, 90-year-olds, 100-year-olds, then actually they're in a better state for their legs to be in. So actually they may need our service, which would be brilliant, wouldn't it, for the future?
It would certainly. And would anyone else like to speak further on that? Sarah, maybe?
Yeah, thanks, Nick. Yeah, absolutely agree, Emily. And you know, I think the real power of the campaign, the Legs Matter campaign, is that that's what we want to achieve. And I think, you know, I often talk to my daughter. She's in her late 20s and she's in a job where she's on her feet all the time. And, you know, I talk about her leg health and she looks at me as if I've gone mad because, you know, why are you talking to me about this when I'm only 28? But you know, we changed, I think, in society. We offer, you know, there's a lot of people in very sedentary jobs, people sat for long periods of time. I'm afraid, you know, we are a bigger nation in terms of our weight. And these are all risks, and I think we need to recognise that further down the line, I could have a leg problem. So part of the Legs Matter campaign, we have quite a nice little checklist. Have you got any of these signs? If so, you need to seek advice now and do something about it, because, you know, in 10, 20, 30 years time, they could be one of these patients that are in Emma's or Emily or Martha's caseloads. So I think, you know, to me, I think it's a public health issue, and I think there need to be adverts on telly and warning people that, you know, this is potentially going to happen. But prevention is absolutely key to all this. I agree.
Emma, I'm wondering if you have anything to add to that.
Yeah, so I think we're all kind of coming from the same point here, but yeah, definitely. I mean, in the clinic itself, I'm still shocked to see patients who are getting younger and younger that present, and I know specifically I can think of one who was only in his early 30s, and the chap was constantly struggling with weight issues, and you could see that I was seeing the mum, and he couldn't quite believe he was, you know, coming to us for effectively leg ulcer treatment. But it was all about kind of talking to him about the importance and how he couldn't believe if he lost weight that it was that much of a factor. So we kind of had a little bet with each other, and we referred him on. There was a local initiative where you could use vouchers for a weight loss program. So we kind of said, I said, oh, you know, I can always do with losing a few pounds. We'll do some bits together. We didn't go to the same program, but we reported each week to each other. And actually, after he lost weight, his leg wounds healed, and he went on to have a lovely girlfriend and still bump into him in town now. So all of those things actually do jump up on people without them realising that they're at risk. And he worked at a desk and ate and drank at his desk, all things that were just convenient, and it's easy to get into that mindset, really. So yeah, it's my perceptions from it. Thanks, Nick.
Thanks, Emma. Now, I missed out Emily once, so I'm not going to miss anyone else out. Martha, over to you on this one.
Thank you. I was just going to say about, again, kind of what you've all covered, but our sort of relationships with the patients are really important in promoting this sort of awareness of what these problems are and how they can be sort of addressed, and making sure that patients have a really good understanding of what it is that's causing those issues. And it tends to increase sort of their concordance with care plans if they know more of what's going on. So definitely any kind of promotion to do with legs would be really good, I think.
Thanks, Martha. Emma, you were referring to the to that younger person you were working with. One of the questions we have had in, and I'll turn to you, Emma, on this one. How do we manage chronic leg ulcers in young people who are up and about? First to you, Emma, and then I think I'll over to you, Sarah.
I think that's kind of quite a broad question, effectively, because obviously we're all going to be of different sizes. We've all got different health problems and health concerns. So I think I wouldn't necessarily deal with somebody of a younger age any differently than I would somebody else that had come through the door. We've definitely, I can advocate the whole, from experience, within 2 weeks, if the wound hasn't healed, I would definitely be looking at, and from experience had success in, you know, doing an assessment. And that's pretty much most of what the assessment pathway was that we created, and it looked at reasons why it wasn't healing, and you know, even if it's as simple as one of us would take a wound swab, another one of us would take bloods because we thought something wasn't quite right, but actually by making it into a checklist and an assessment that we covered all the bases, it did actually mean that, you know, maybe things like early diabetes was picked up, or other factors. Maybe there was a wound or something that had become infected that wasn't initially obvious when you're initially assessing it. So in my opinion, you know, still the same things, regardless of age. You have to look at everybody as you know, their own individual, and assess them as an individual, and why at such a young age, really, I suppose, would be my first question. Has the wound not healed? I think that would probably be where I would go from a clinical decision-making process. So thanks.
No, thank you very much. We'll come on. We do have a question specifically about service users with diabetes, but Sarah, over to you on the question about managing chronic leg ulcers in younger people who are up and about.
Yeah, I mean, like Emma said, you know, if it's a chronic leg ulcer for somebody who's young, I would question why they're not healing. So there's possibly some underlying issue going on. You know, in certain ethnic groups, you know, you've got things like sickle cell, there's some rheumatoid or vasculitic sort of conditions which maybe need to be explored. I would say that if there's nothing sinister going on, and it's a matter of, you know, they could have had a road traffic accident which damaged their limb, or they've had a deep vein thrombosis in the past which is causing problems with healing, or, you know, we have to rule out the certain groups in our community who have been IV, you know, injectors into their limbs, and that can create real problems with their veins. But ultimately, I think, you know, the younger population certainly should be the group that are self-caring, and I think we need to use that as the default model, but with an open door policy that if there's any concerns, who they come to, rather than you know, what we don't want them to be struggling on their own for weeks on end before they sort of have access. So self-care, I think, is key, because that provides, you know, it prevents a problem with trying to come for appointments in work times or leisure times, and they can do their dressings, you know, whenever it's convenient to them. So hosiery kits are brilliant for this. Bandaging is quite tricky to apply to yourself, but we have also taught relatives, next of kin or whoever, to apply bandages, but hosiery kits are ideal. But I would question why somebody in the younger age group isn't healing, and just need to make sure, like Emma said, that all the investigations have been completed. But self-care is key, I think.
Thanks, Sarah. Emily, I think, am I right in thinking you wanted to, or you had something to add to the conversation on this one?
Emily, you just need to unmute, sorry.
So, yeah, I think, you know, at the moment with COVID, everyone's work-life balance has changed a lot, and actually we are sitting down for longer periods as well. And actually, I think the younger generation may be affected by that much more than previous generations as well. You know, using the internet, to Microsoft Teams, for example, to go on to panelist shows and everything else. So I think that's really important to promote for our youth. I also think actually the use of technology with our people that might be more savvy with IT, so we can monitor their conditions easier using digital consultations, for example, might be something we could explore further to help our younger. And I'm not saying that older people can't use the IT, but it does tend to become more easy to the people that use it every day with their work, and that might be something to look in the future to help the monitoring process for our young.
Great, thank you, Emily. You mentioned COVID. We're never, unfortunately, that far away from that. I was hoping to explore really a little bit about people's experiences of the COVID pandemic, and maybe this could relate in some way to what Sarah was talking about earlier about you know, a collaborative approach and reviewing priorities and how to make, you know, change happen. Are there lessons from that we've learned over the past however many months it's been to improve services more generally? Sarah, I'm going to come to you first on this, but then I will come to others as well, Emma, Emily, and then Martha, if I may. Over to you, Sarah.
Yeah, I think, I mean, there's been an awful lot written since COVID about service redesign, how we've done things differently. And I think that is being explored at sort of a sort of higher level, and certainly the national strategy, you know, have been involved in that work. I think what it has, I think in the early, when we sort of first went into COVID, there was a bit of a knee-jerk reaction in terms of how we manage patients with leg ulcers, and there was real variation across the UK. Some stories not so good, some excellent stories. You know, there were some stories maybe where, you know, patients were encouraged to self-care but didn't have the support, but also just some amazing stories of how we work differently to enable a decent service. So I think self-care was key to that, but it's around how we supported people to self-care. But also I thought what was really good is that it's always been very much a nurse-led service, lower limb care. And I think what COVID has taught us is that the benefits of integration. I think we've been a bit siloed in the past, so there'd be tissue viability, there'd be podiatry, there'd be vascular, there'd be district nursing, practice nurses. But what COVID, I think, has done is brought us all together, and actually there are skills we can learn from each other. So certainly when I was in Oxford before I left, we had podiatrists doing ABPIs and putting compression on, so they'd never done that before, and us, you know, learning skills from podiatry, for example. You know, care home support service, who normally wouldn't bandage, were being given training so they could develop that. So you got quick assessments and early intervention of effective treatment. So I think, you know, there has been some amazing stories of how COVID has enabled us to work better and to get sort of, you know, patients on the road to recovery in terms of healing. But I'm sure Emily and Martha, and I'm sure Emma as well, can tell us sort of other stories as COVID has progressed.
Absolutely. Emma, over to you.
Yeah, thank you. So speaking obviously from a primary care point of view, that there is different, it's always different from one surgery to another, because they're all sort of unique businesses, so to speak. But certainly during COVID, there was definitely an element of where I was contacted quite more frequently, because the leg ulcer set clinics where, as a rule, the general rule of thumb is that patients are with a practice nurse for 6 weeks, and if it hasn't been healed, then you would then refer on to a tissue viability or district nurse-led type clinic. But all of these were like stopped within our local area, and so obviously practice nurses, we were all having to be inventive, where perhaps they had felt like, you know, because they hadn't had the training or compression and doing Dopplers, etc., was not something of their usual routine. It was something that had to be quickly sort of worked around. Training was put in place, where lovely stories of healthcare assistants who are very, very competent, knew the patients just as well as some of the qualified nursing team, had all kind of worked together, really. And so it had meant that the bringing the patients to the surgery also, where you know, perhaps there was sometimes this twice a week element, we were trying to look around, and so it kind of in a way pushed some of the surgeries that had been reluctant to take on board doing more assessments and getting training into compression because that wasn't something they'd previously done, it's been really good to now see that the training has been put in place, and actually the skills of practice nurses have developed tremendously, because, and healthcare assistants who play a fantastic role. It's been great that now they have got the capacity and the confidence really to know that they can do the Doppler and do the work for themselves. So I think initially COVID was a slight negative as far as leg wound management for those that hadn't had very much knowledge on it, but certainly now I think again, lots of contact now with the hospital. I certainly wasn't in as much contact with the vascular team, dermatology, and with the tissue viability nurses up at the hospital. We've all now had to email, send pictures to each other and work more collaboratively together. So again, another really lovely positive that's come out of it. And it's great. These relationships will help the patient, really, won't it? So all in the end a negative, but lots of positives again, like Sarah has to say.
Fantastic. Thanks, Emma. Before we move on that question to Emily and Martha, and I really would like, I'm sure we would all like very much to hear their points of view. Emma, have you come across, and really it's a question to everyone here, the question is, has anyone seen any examples of the condition COVID skin? Emma, you first on that.
No, to be fair, where I'm working at the moment, we're quite rural, and rates of COVID within Suffolk have not been as high within the town as other places. So fortunately is how I would look at it. We haven't had much impact from where I've been working hands-on with patients who've presented with that type of skin condition. So I'd be keen to see what everybody else's experiences were of it.
Great. And on that note, then, just to bear that last question in mind, over to you, Emily, about what we have learned and can have learned from the COVID experience. Over to you, Emily.
I think from certainly Oxford Health point of view, we did a lot of work around the self-care element, which Sarah's already talked about quite a lot already today. We had to do a lot of work about the governance and quality of what that would look like as well with our patients and their carers and families. That's something certainly we want to promote, because actually it's ownership to the patient, isn't it? It's given them back the right to say, what do you want out of your legs? What's your achievements? What's your goals? So we have done quite a lot of work around that, and around the COVID when it started, when people were being furloughed for long periods of time, it meant that many people had much more larger family support at home. I know that's slightly changed now with people returning back to work. So that's something that we've done. We've also done quite a lot of MDT work. So again, Emma's already touched about increasing skills for other people, but we've actually been working quite closely with our therapists in the community as well. So actually, if they're already visiting a patient, trying not to have a large footfall through that patient's doors, because that increases risks of infection. But actually, is there things that the therapist can do to just monitor the legs, to check out and then raise the alert back to the district nursing service for tissue viability? So actually it's getting those skills across therapy and nursing together to work together to be the eyes and ears for our patients. Also touched already on about digital consultations and how we can use that. Very hard in district nursing, I think, but this certainly opened questions on how we can use that further going forward to work more effectively and safely. And that's a question that's come up from COVID, and I don't think we would have pushed it as much a year ago as we would now. And actually the teams are working very differently. They are using the internet to do their handovers and touch and base. They're not coming into the offices. And in one way that's really sad, because actually they're losing some of that relationship building within the team. But in another way, they're also working really effectively. They're still getting to touch base. They can still see their peers on a regular basis. And that's things that we've done. And lastly, that handing over to Martha, but she'll probably be in a better place to talk about it, how the tissue viability team specific to Oxford Health and how it works within district nursing has changed. They've become much more integrated into the community nursing teams, but I'll let Martha talk about that.
Lovely segue there, Emily. So Martha, over to you. I'm no longer needed here. My work here is done. Over to you, Martha.
Thank you very much. So yeah, kind of touching on what both Emma and Sarah and Emily have all said is that we've really had to adapt the way we've been working due to COVID, and there's some really great examples of how that's helped us as as community nurses, and also me and the tissue viability team now. But particularly the use of technology, I think both as a community nurse and as a tissue viability nurse, the relationships that I've been able to build with other services like continuing healthcare, the care home support service, the district nurses, nursing homes, the whole lot of them. It's so much easier and more convenient for us to meet over Teams, and you really feel like you're having that kind of chance to build those connections and get to know those services and how they work, and that sort of feeds into how we can work better as a multidisciplinary team, and we sort of have more access to those services, and yeah, it's just better outcomes for the patients really. As a tissue viability team recently, we've moved to a more locality based model of working, so we've now sort of got designated TVNs for each area within our county, and that's again helped us to further develop those relationships with perhaps the district nurses, the practice nurses, and they know more who we are, so we're a lot more accessible to them. I think that's really positive, some things that have come out of COVID and changing the way we work and things. Thank you.
Thanks very much, Martha. I think there's one more COVID question, COVID-related question that I'd like to ask, and really this one's for Emily, I think, to kick off. We've looked at the past and what COVID has taught us. This question really relates to things in the near future. Has COVID resulted in lots of patients resorting to Dr. Google? And do we think that there are lots of patients with undiagnosed significant problems that will hit the NHS services in the coming months? Over to you, Emily, on this one.
Well, I can't exactly comment on the rates, but I imagine so. Google is everyone's friend when something's going wrong, isn't it? So be it healthcare or anything else. So I think, yeah, of course people are, and I think that's part of a community nursing role as well for the patients and families we do see. It's about actually saying, giving them real education about their diagnosis or their future plans and their expectations, and managing those expectations rather than just going through Google. And Google's a scary place. I mean, if you start Googling things, you do kind of think, oh, about everything. So I think we need to manage that as well as nurses and healthcare professionals, full stop. I think the world of COVID will have thrown up a massive amount of issues going forward. Going on to leg ulcers and frailty actually are the people that have been staying at home for the last year, 18 months, that were already frail, that we might have touched base with, but haven't gone to their GPs because of underlying conditions, and they didn't want to be bothered. They were scared about getting infections. Actually, are they sitting at home and we don't know about them, and actually they're becoming frailer and frailer? So actually I think that's going to be part and parcel of the COVID, as well as anything undiagnosed anyway on the day-to-day scheme of things. Have we made our frailer patients more frail because actually we've enabled or disenabled them by leaving the house and being mobile and that side of things? Also, then there's also the mental health, anxiety, depression, the dementia, the carers as well. I mean, these are all elements that when our social skills have been taken away for the last 18 months, they're going to be massively impact on physical health as well as mental health. And that's again something which then goes on to patients keeping their bandages on, wanting to be wanting to get their leg healed. If they're depressed, then are they going to be fully participating in their care. And that all goes back to how successful their treatment's going to be and everything, but including leg ulcers as well. So I think COVID has opened up a big can of worms for the healthcare system, and that's not going away, and that will be affecting us for years to come.
Thank you, Emily. Anyone else want to add anything on to that? Is that a yes from Sarah?
Yeah, I think there probably will be people out there that have problems that probably need to be addressed. However, they have to recognise they've got a lower limb problem. And that's why I think it's so important that we raise awareness of when something isn't normal. And again, the Legs Matter campaign is very much into that, in terms of recognising that swelling isn't normal, a non-healing wound isn't normal, a lesion that bleeds regularly isn't normal. So I think, you know, over time, I think, you know, when we try and raise that level of awareness, it will get better. But obviously, if there are people sat at home today who've been locked down for most of the year with these problems, they have to recognise that it's not right. And they need to know who to go to get that resolved. So I think, you know, people probably have slipped through the net, but it's our responsibility, whether it be through a charity like Legs Matter or through the NHS, to try and find these people and get them the right care.
Great. Sorry, I didn't wasn't there quite on time. Thank you, Sarah, very much for that. Just to change tack a little bit, enough about COVID for the time being. You mentioned, this one's for you, Sarah, you mentioned the use of Doppler in your presentation. We've got a question in. I'm keen to get the opportunity to use and gain experience with Dopplers. Would you advise contacting tissue viability nurses? And some more general advice perhaps about how the use of Doppler in its role in diagnosis and management. Over to you, Sarah.
So Doppler, or gaining an ankle brachial pressure index, an ABPI, is part of the recommended vascular assessment for lower limb wounds. So we should always be attempting to try and get an ABPI recording. However, there can be challenges for that, whether that be a skill set from those that are undertaking it, or whether it's because the patient's limb is very painful, because obviously we're putting a cuff around the ankle, or whether the patient's anxious or the limb is huge. So I think we have a responsibility, if we're a provider of these services, to ensure that staff are skilled in doing it and they have the right equipment. But there are sort of alternatives now. They are bringing out sort of automated ABPI machines, which are a little easier if you are anxious about doing the standard handheld way. So that is an option. Tissue viability, usually, I can only speak for the service I used to work with, we did provide training for ABPI as part of our leg ulcer training, but again, industry is a good source of providing that as well, particularly those who provide the equipment that you might be using. But I think we have to somehow break the barriers down about the nervousness of ABPI, because it will stop us putting in an effective treatment plan. Because if it doesn't get done because people haven't got time, they say, which shouldn't be an excuse, but I'm afraid time is an issue, but we need to look at that somehow, or whether people haven't got the skills or the equipment. There are, if you think about that immediate and necessary care right at the beginning of the recommendation, is it's giving you permission to put compression on without an ABPI. There's a really good position statement, a document, a best practice statement from the British Lymphology Society that talks about you probably are doing more harm not putting compression on than putting compression on, if you know, around if you haven't been able to get an ABPI, and it really brings those red flags up again. And so read that, because it does we need to get to the point where people have got more confidence around making those decisions. But I think we have a responsibility, as I said, to ensure that staff have access to the equipment and the right training, but that can be found at various resources. As I said, tissue viability, industry, it's out there, definitely.
Lovely, thanks, Sarah. Martha, I'd like to bring you in and to respond to to some of the things Sarah was saying about Doppler, the ramifications that may have for the team you work with and the patients you serve.
Absolutely. I mean, Sarah's absolutely right. There is a lot of resources out there for nurses to gain information about Dopplers and ABPIs and things. I think within your services, if you are struggling to sort of get a handle on that side of things, then that should be something that you can escalate and actually request training for. I do think with the Dopplering, the ABPI is not necessarily the only diagnostic tool that we use in the diagnosis of lower limb ulceration. So, you know, you need to be thinking of that as sort of the cherry on top of the cake and looking at your lower limb assessment and just a holistic assessment in general of each patient individually. But yeah, certainly, you know, it is recommended that you have a Doppler, but like Sarah was saying, it's not always possible. So it's sort of weighing up the pros and cons really, and where you can get them, fantastic, and where you can't, what else can we look at and how else can we make sure we make a safe decision around care.
Thank you, Martha. Thank you, Martha. That's grand. We've got a couple of very, I mean, obviously this session has covered a pretty wide range of topics. I'd like to return to some very practical questions here in our closing minutes, because I think it's important that we do keep it as practice focused as possible. So I'm going to turn to Emma for this one, if I may. It's about dressings for, well, I'll just read the question. What is the appropriate dressing, or what are the appropriate dressing for heart failure patients with swollen, leaking legs? Over to you.
Okay, yeah, so again, that's quite a tricky question for me to answer because it's quite broad, but basically, again, you know, this is quite common. This is obviously something I saw more when I was working in the community, more so than where I am now in practice. But it is again about making sure if it's okay and it's appropriate for them to be in compression. I hope Sarah agrees with me with this, but I would definitely always aim, you know, as best as possible, and every single patient, if they can be in compression, they will be in compression. As far as the wounds go for leaking, obviously there are various different types, and again, our formulary particularly keeps changing, so I would recommend looking at what your local formulary is that they recommend for you to use. From my own personal perspective, there's obviously various different, you've got the traditional larger pads, but then there's more things out on the market now that are more absorbent and are thinner and actually sit quite nicely underneath the compression. With those patients, I would definitely go for twice a week. Obviously, normally I would say if there's no strike through, leave the compression on for a week. But with a heart failure patient who's got lots of fluid leaking, and then all the obvious holistic elements where, you know, they need to get the doctor perhaps to, or, you know, depending on what level you are, if you can look at diuretics and what their kidney function is, and get that balance of, you know, getting the doctor to work out whether there's anything they can still do to juggle the factors of what's going on. One element has an impact on another, and also, you know, just to make sure that if it's strike through and it's wet, obviously try not to let the leg get too macerated, really, because then further elements of the leg will break down. So quite a broad, very patient specific, really, but definitely a lot on the market, and obviously juggling with heart failure team at the hospital and any GP to make sure that they're on the correct medication that can try and balance that as best as possible, really.
Thanks, Emma. And your suggestion over to Sarah on this one, just to follow up on that, and possibly Martha, maybe you had something to add on that. As that's a smile I see there, so I'm taking that as a yes. But over to you, Sarah, to start off with.
Yes, I think there's been a worry about the heart failure and compression sort of combination, and there's always, I think, people have been quite nervous to the detriment of that person's quality of life and their limb and their healing. I think the majority of people with heart failure can safely go into compression, but again, it's establishing what sort of heart failure they have and to work closely with maybe the specialists to enable compression to happen. You know, I can still now picture a guy I remember visiting in at home who sat with his legs in bowls filled with exudate dripping into them because his legs were so swollen and he'd been told he couldn't have compression because of his heart failure. And, you know, it was just totally unacceptable that he was living in those conditions. So in fact, he was quite fragile in terms of his heart failure, but we concluded that what is better, to take a slight risk and a chance of putting the compression on, or to continue to live like this? So we did admit him to one of the community hospitals, and we just gradually introduced compression, one leg at a time. And within a week, this man's legs were dry, and he was overwhelmed with emotion that actually, he hadn't got to live like that anymore. So I think until you get things under control, compression is going to sort that problem out. Wet legs is not a diagnosis. We hear it all the time. It is not a clinical diagnosis. It's a consequence of an underlying condition. And unless we manage that, it's not going to be resolved. And compression really is the only thing that's going to resolve it. If they've got proper heart failure, of course, diuretics, etc., but it's the compression. So we need to be working, as I said, collaboratively with various, in a multidisciplinary way to address this. In terms of dressings, we use a step up, step down sort of approach to dressing. So while it's really acute, water sprouting out of those legs, you need a really good absorber. So, the high-tech super absorbers, which fill very quickly with fluid. And of course, under compression, it will change the sub-bandage pressures. But again, it's fine to do so as long as this is being closely monitored. And once the compression works and that edema starts to reduce, the exudate level will come down. So in time, you need to reassess and then maybe step down to a less absorbent pad, and then you can go down to your simple dressings. But it doesn't mean, that you start on the lowest and just think, let's see how it goes. Assess properly, get the right absorbency, get the compression on if you can, and then step down when it's ready to do so. Thanks,
Great.
Nick.
No, Sarah, thank you very much. Martha, really quickly, you have 10 seconds.
Of course, I was just going to say Sarah's pretty much covered everything of what I was going to say, just that in the recommendations for clinical care, it does actually say there about people with advanced unstable cardiac failure to liaise with their cardiac clinicians or, whoever's looking after their sort of heart failure in order to figure out a way to safely compress them. So, yeah, that's it from me, really.
Lovely. Thank you. Yeah, I'm back on. Lovely. Thank you very much indeed. Thank you everyone who's taken part in this webinar. It's been a fantastic 90 minutes. Thank you ever so much, everyone. Thank you. Just to run through you, Sarah, Emma, Martha, And Emily, and thanks for giving up your time today for joining us. I hope everyone's enjoyed the afternoon and found it useful. Just reading from my notes here, there'll be a certificate of attendance for your revalidation portfolio, and that will be emailed to you early next week, along with an evaluation form, so you can tell us how you found the event. So please do that. For people who have submitted a question that hasn't been answered, or if you weren't able, if we didn't have time for that, or you weren't able to submit a question just now, we've put up contact details which you can email to, and I think that about covers it, everybody. So at 1:30 precisely, thanks again for joining us, and goodbye. Take care, everyone. Thank you. Stay safe. Bye-bye now.